Hi, my name is Corrie Holland, and I'm a Doctor of Nursing Practice student at Maryville University, and today I'm going to present to you my D&P Quality Improvement Project titled Reducing Congestive Heart Failure Symptoms and Readmissions Through a Standardized Management Program. Introduction. Congestive heart failure, or CHF, care has cost the healthcare industry more than $30 billion as of 2012. It is estimated by 2030 to cost healthcare more than $68 billion. CHF is also the frequent reason for admissions and readmissions, and CMS identified an excessive readmission rate of 20% for Medicare patients alone in 2012. Because of the excessive readmission rates for CHF, the Affordable Care Act of 2010 required the Department of Health and Human Services in 2012 to establish a readmission reduction program, which gave incentives to hospitals for reducing readmissions. In 2014, Medicare started reducing reimbursement for hospitals by 3% for readmissions for CHF, as well as other conditions. Introduction continued. During my practice in the outpatient cardiology setting, it was clear to me that patients were not following self-management guidelines. But it was also unclear if teaching was occurring in the outpatient setting or if follow-up was occurring with medication review and adjustment if needed. All of these are key elements to managing heart failure and are very important. By successfully managing heart failure, patients are able to reduce congestive heart failure symptoms. They're able to reduce readmissions. They're also able to reduce penalties incurred by hospitals for readmissions. And most importantly, this improves their quality of life. During the literature review, 3 themes were identified. The first theme identified was reducing congestive heart failure readmissions. This theme included tactics such as early follow-up within 7 days or 2 weeks of discharge, collaborative care with the PCP and specialist at follow-up, and also included cost effectiveness of nurse-led programs as follow-up with familiar physicians and personalized follow-up care, and also looked at patient factors that influenced readmissions. The second theme identified was self-management of heart failure. The literature showed that better self-maintenance with early and routine follow-up. It showed greater knowledge in self-care maintenance with the teach-back method. It also showed that nurse-led CHF management led to better self-care and quality of life. Readmissions were cut in half by providing education materials and in-person education, and inpatient CHF self-colleges reduced 30-day readmissions by 4% in a study by Greer et al. Continuing with the self-management theme, research also showed lower 30-day readmissions rate with bedside education, and early self-management education impacted readmissions. The third and final theme identified by the literature review was early outpatient follow-up. Early follow-up versus not led to critical medication adjustments, lifestyle guidance, and less readmissions. Follow-up with a familiar physician also had the lowest readmission rates, and follow-up within 7 days lowered mortality rates and readmission rates in one study. Follow-up within 10 days, another follow-up after 20 days, and then monthly follow-up for a total of 6 months reduced readmissions in another study. Comparing pre- and post-intervention periods, the post-intervention period was associated with more cardiology follow-up and lower readmission rates within 30 days in one study. Follow-up within 2 weeks with a primary care physician and cardiology or at least a heart failure clinic resulted in reducing readmissions. Follow-up within 7 days resulted in lower readmissions at 30 days and also at 90 days post-discharge. And it showed double the rate of collaborative care with a primary physician and overall more thorough care. The theoretical model used for the D&P project was the trans-theoretical model of health behavior change by Prochaska and Velser. This applies to the D&P project as it requires numerous interventions designed to change a person's behavior. It was constructed around stages of change and highlights that it is an ongoing process. There's 5 stages in the trans-theoretical model, which include pre-contemplation, contemplation, preparation, action, maintenance, and termination. With the CHF self-management, this is a process, and it requires overt and covert actions on behalf of the patient. This applies to the trans-theoretical model, as many times congestive heart failure patients need to change their behavior in order to successfully manage their disease. The DNP project aimed to standardize outpatient care through a management program, included early follow-up within 14 days of discharge, review of medications and adjustment as needed for better management of fluid status, and reinforcing education that included lifestyle modification such as low-sodium diets and weighing themselves daily and monitoring their weight, recognizing CHF exacerbation symptoms, which, if caught early, could decrease an exacerbation and hospital readmission. The DNP project goals were to reduce exacerbation symptoms and readmissions for congestive heart failure patients and to give patients tools to manage their heart failure successfully. Significance to nursing. Patient education about heart failure begins with nursing. During their inpatient stay, patients receive congestive heart failure teaching fundamental to managing this disease from nurses. Nursing's role in starting this teaching is imperative to CHF management success in the long term, leading to better quality of life, fewer symptoms experienced, and fewer hospital admissions. When it comes to significance to healthcare, healthcare will benefit from standardized management of congestive heart failure by early outpatient follow-up after discharge and early identification of exacerbation symptoms. This will benefit them by improving their health and quality of life, and through early follow-up, medication review and adjustment, and reinforcing teaching, patients will learn to better manage their CHF. Secondly, healthcare facilities will benefit from this as well in a fiscal manner. By reducing hospital readmissions, healthcare facilities will not be subjected to CMS's 3% penalty related to readmissions within 30 days of discharge. The DNP project on outpatient management of congestive heart failure is significant to advanced nursing practice by continuing inpatient management and teaching in the outpatient setting. Advanced practitioners can adjust medications as needed and explain medication's role in managing their CHF. They can also reinforce lifestyle modifications and teaching such as diet and daily weights. Methods. The DNP Quality Improvement Project employed a quantitative exploratory design. It was conducted at an outpatient cardiology practice from May 1st to July 30th, 2023, and the sample consisted of 54 adult patients. Inclusion criteria for the sample obtained included patients that were 18 years of age and older, patients that followed with the cardiology practice where the project was implemented. Patients had to have a congestive heart failure diagnosis, and they also had to have a recent hospital admission. Exclusion criteria for the sample included patients that were less than 18 years of age and older, those that did not follow with the cardiology practice, those that lacked a CHF diagnosis or a recent hospital admission, and those that were being discharged from the hospital to palliative or hospice care. During the data collection period, post-discharge patients were placed in one of two groups, the CHF Management Program group or the non-management program group. They were placed in one of these two groups dependent upon if they followed up with the cardiology practice within 14 days of discharge. If they did not follow up within 14 days of discharge, they were placed in the non-management program group, and if they followed up within the 14-day time period, they were placed in the CHF Management Program group. Data collected for the DNP Quality Improvement Project was nominal. It was collected on a data collection sheet that was created specifically for this project. When data was collected, all patient identifiers were removed, and the data was collected via retrospective chart review. The retrospective chart review specifically looked for if follow-up occurred in the office within 14 days of discharge, if heart failure education was provided, if medications were reviewed and adjusted at that follow-up visit, and if they experienced any exacerbations or a readmission in the 30 days post-discharge. The data collected was analyzed using the z-test for the difference of two proportions and SPSS. These were used to determine if there was a statistically significant difference between the groups. The descriptive statistics was utilized. It assessed incidence of exacerbation symptoms and readmissions and included patients in both the management program and those not. On this slide in Figure 1, you see CHF program exacerbation symptoms experienced and readmissions. You see a comparison between those in the program and those not in the program. In Figure 2, this is a visual of patients who experience exacerbation symptoms, again comparing those in the program versus those not in the program. The DNP project employed certain measures to protect subjects included in the project. Details of the project were kept vague, such as the location and the cardiology practice. Data was collected via retrospective chart review, and during that collection, patient identifiers were removed. Subjects were exposed to only a minimal risk of breach of confidentiality, and all information was stored on a password-protected computer in a secured location. Ethical aspects of the DNP project. Approval from the Institutional Review Board of Maryville was obtained, but was not required at the institution for which the project was implemented. There were no physical, psychological, social, economic, or legal risks because of the project, and the project complied with the Health Insurance Portability and Accountability Act. Results. Setting and structure of the DNP project. The DNP project focused on outpatient cardiology follow-up and happened at a cardiology outpatient office. Specifically, it looked at patients discharged from the hospital after a CHF exacerbation and admission. Communication occurred through messaging from the hospital cardiology team to the medical receptionist in the cardiology office about patients that were being discharged and to set them up for a follow-up appointment. Once the medical receptionist received the message, a follow-up appointment was then scheduled. Setting and structure continued. The researcher was then provided a list of discharged patients. The sample population included 54 congestive heart failure follow-up patients. 39 of those patients were enrolled in the management program, and 15 were not enrolled. The next slide, you see Figure 3, which is the project implementation timeline diagram. The first step is the planning phase, for which a needs assessment occurred, and there was collaboration with the practice manager and lead physician. This happened during July to April of 2022. In the next step, you see development of the standardized CHF program, which included discussion of barriers to decreasing readmissions, creation of the actual standardized management program, and this happened during July to April of 2022. The next step was IRB approval, which was obtained from Maryville University, and there was also approval to conduct the project obtained from the health network, for which the cardiology practice belonged to. This happened July to April of 2022. The next step is education. That was presentation of the CHF management program, as well as education on the program that was given directly to the staff at the cardiology practice. This happened during March to May of 2023. The next step was implementation, where the CHF management program quality improvement was actually carried out, and this happened from May 1st to July 30th of 2023. The next step was the results step, for which the EMR was reviewed, data analysis occurred, and this was from June to August of 2023. For this study, a z-test for the difference of two proportions was used to determine if there was a difference between those enrolled in the outpatient standardized congestive heart failure management program versus those not enrolled, and looked at specifically exacerbation symptoms experienced and readmissions that occurred. The p-value from the data from the two groups in relation to exacerbation symptoms experienced was 0.7285, which was greater than the significance level of 0.05 and therefore was not sufficient information to suggest a decrease in the ratio between the two groups. Also, you can say the p-value in relation to the occurrence of readmissions was greater than 0.5754 and therefore was also greater than the significance level of 0.05. These results show that there was no statistical significance found between the two groups. This suggests that current CHF management may not be effective in reducing exacerbations and readmissions, and more research is needed into strategies to manage this population. An unintended consequence of the DNP project was the a priori determination for the sample of 154 patients to be included was not met. There was only 54 patients included in the sample. A short time frame of 2 months may have contributed to only getting 54 patients included in the sample. Because the a priori determination for the sample of 154 patients was not met, this likely led to missing data. The strengths of the DNP project include the fact that it highlighted that the current standard of care is not reducing readmissions. It also makes us now aware of the lack of standardized outpatient congestive heart failure management that is occurring. This provides us a launchpad for looking at the problem from a different angle. This can also spark the creation of other protocols and new ideas about outpatient management of congestive heart failure. Limitations include the small sample size, as only 54 out of 154 patients were included. The short time frame of 2 months also was a limitation because it likely contributed to the small sample size. There also was likely not enough time in those 2 months to obtain the predetermined number of patients. And likely these limitations did affect the project's outcomes. Nursing implications from the DNP project include that current practice, as mentioned before, is not ideal and must expand to include other management tactics. These include telemedicine care, earlier post-discharge follow-up visits with cardiology, for example, within 1 week of discharge, and utilizing visiting nurses services to do the same thing the congestive heart failure management program would do, such as reinforcing education, monitoring symptoms patients may be experiencing, and reinforcing lifestyle modification such as diet and daily weights. Implications for future research including exploring other ways of managing this population and looking at the problem from different angles. Implications also include investigating improving outpatient interventions and management by utilizing things previously mentioned, telemedicine, visiting nurses, and earlier follow-up. And you could combine any new research with current interventions in an attempt to improve management of heart failure. In conclusion, the DNP Quality Improvement Project created a standardized outpatient congestive heart failure management program for post-discharge patients. This program included follow-up within 14 days of discharge, and at that follow-up, medication review and adjustment as needed, reinforcement of teaching and education provided in the inpatient setting, specifically about recognizing exacerbation symptoms. This program aimed to decrease 30-day readmissions and exacerbation symptoms experienced by this patient population. The project findings showed that patients who were enrolled in the congestive heart failure management program did not in fact experience fewer symptoms or readmissions when compared to those who were not enrolled in the program. A recommendation for moving forward based on these findings would be to think outside the box about how we are currently managing these patients. New tactics and ideas for closer monitoring them during the post-discharge period must be created. Protocols that are currently in place must be updated and changed in order to improve this population's well-being and how they do in the post-discharge period. Lastly, another recommendation would be to continue to grow the outpatient management of CHF patients so it is as thorough and used as frequently as the inpatient management tactics are. Here is a list of references used during my presentation. Page number 2 of references. Last page of references. Lastly, a big thank you to all of you for your patience and kindness in taking the time to watch my presentation, and a big thank you to all my fellow students and the staff of Maryville for all your valuable feedback.